Veins are much harder to do than arteries. Don't start working on veins until your arterial anastomotic technique is excellent. If the last artery that you did looked like this, then you're ready to go ahead and try a vein. But if it looked like this, you need to go back and do some more arteries. If that's the case, don't watch this tape until later. I mean it. Here's why veins are so much harder than arteries. First, it's difficult to dissect them out in just the right plane. Second, it's extremely easy to damage them in the course of preliminary dissection. Lastly, the vessel wall is so much thinner. Look, here's an artery, here's a vein. You can see the thickness of the arterial wall, and the wall is stiff enough that the end of the artery stands wide open. By contrast, look at the vein. The wall is almost invisibly thin, and it's so floppy that the vessel end collapses, unless it's underwater. Your success in doing the anastomosis is going to depend entirely on your success in carrying out the preparatory steps of the procedure. If, by successful preparation, you get two vessel ends looking like this, you'll have set yourself up for a successful anastomosis that ends up looking like this. If you're unsuccessful in your preparation, your vessel ends will look like this, which is a setup for disaster. Here's what you end up with: a mess. With that in mind, let's begin at the beginning. In watching this dissection, watch just how gently everything is being done, and make up your mind that you'll do everything at least as gently as that when you carry out the procedure. Start on a fresh side that hasn't had anything done to it. Be gentle from the very beginning. In getting proximal access to the vessel, pull quite gently on the abdominal wall while you get these adhesions divided all the way up to the inguinal ligament. If you pull too hard on the abdominal wall, like this, you'll stretch that ascending branch and hurt it, and get a big thrombus starting right here and spreading into the femoral vein. It's important now to find the vascular sheath, because we get inside that sheath to free up the vein. First, get rid of this very loose tissue that's lying in your way. Now, to see if you're down to the sheath, try picking it up over the artery. Here it's easy to recognize. There's the sheath. Now pick up the sheath over the vein. It's not quite so easy to recognize here because it has no vasa vasorum in it, but that's the sheath. Now that you have it picked up, make a little hole in it with the tip of your dissecting scissors. There's the hole, with the naked vein lying right inside it. Now pick up the edge of the hole and start dividing the vascular sheath, keeping the scissors carefully flat against the vein to avoid puncturing it. Go on dividing the vascular sheath all the way down to the epigastric, alternately probing and cutting with the tips of the scissors and keeping in just the same tissue plane. Now go back up to the top and start freeing up the far side of the vein. Push the vein away from the surrounding sheath and the adjoining artery, getting right down between the vein and the artery. Continue holding on to the edge of the vascular sheath with the left-hand forceps. That's the far side. Now for the near side. Use just the same technique again. Be gentle. As you come down here, you'll come across one or two tiny branches. Be very gentle with these branches or you'll hurt the main vessel. First, free up the branch, and then buzz it with the bipolar coagulator. Not here. That's too close, but away from the vessel, out here. Have the bipolar coagulator turned way down when you do that. Now for the underside of the vessel. Till now you haven't had to pick up the vessel. Now you must. That's not easy because there's almost no adventitia on the vein to pick it up by. To get a firm hold, touch the vessel wall with the forceps almost closed. Scoot them along a little to gather up a wad of adventitia like this, and then close them, and you've got it held. With the vein held, pull it up and to one side in order to expose the underside of the vein. Separate the underside of the vein from the back of the vascular sheath, always using the gentlest of movements. As you progress along the underside of the vein, Murphy's branch begins to come into view. Leave it till last. Concentrate on getting the rest of the vein well mobilized before taking care of Murphy's branch. With the rest of the vessel fully mobilized, free up enough of Murphy's branch that you can deal with it easily. You don't want to be cramped for space. Be prepared to spend a little time and patience in this potentially troublesome corner. Sometimes Murphy's branch has many side branches coming in right here. Now, ligate the branch with a piece of 10-0 nylon close to the main vessel. Having ligated it, take the bipolar coagulator and buzz Murphy's branch gently but thoroughly, taking care to keep the bipolar forceps away from the main vessel. You need the bipolar coagulator turned a little higher for that maneuver. Now, finally, divide Murphy's branch and the mobilization of your vein is complete. At the outset, I mentioned gentleness. Now I'd like to spend just a few minutes explaining exactly why gentleness is so important. In a vein, it doesn't take much in the way of unintentional trauma to produce a big thrombus, and it doesn't take much in the way of a thrombus to produce a big problem. Let's look at some actual thrombi. Each thrombus that I'll show you here was the result of an injury that had been carried out just 5 minutes earlier. In some cases, the injury was really small. Here's a vessel that's just been dissected free. There's a little thrombus in it. That little pale object right there. Let's open up the vessel to see it better. There it is, just below the upper pair of forceps. This blob of platelet aggregate, which occupies about a quarter of the lumen of the vessel, was produced by the simple mistake of doing this, picking up the full thickness of the vessel wall, rather than picking it up like this by the adventitia. Here's another thrombus. It's a bigger one. This one was produced by deliberately using the bipolar coagulator too close to the main vessel, like this, instead of keeping it away from the vessel, like this. Here's an even bigger thrombus. It arises right here at Murphy's branch. This one was caused by a major insult to the vessel, doing this with scissors, instead of using the scissors gently, like this. So you can see why gentleness is important. Now let's look at some practical points about platelet thrombi. Little platelet thrombi will go away in time if you leave them alone with the blood running past them. Look. Here's a little thrombus from an injury that was done just 5 minutes ago. Here's the same vessel after 20 minutes of blood flow. The thrombus is gone. the platelets have deaggregated and the blood flow has swept them away. But if you have a fresh platelet thrombus in a vessel and you clamp the vessel, bringing flow to a halt, something quite different happens. Look at this. Here's a fresh thrombus. We clamp the vessel on either side of it and leave it just standing still for 20 minutes. At the end of that time, we've got this, a huge propagated blood clot caused by the action of the platelet thrombus on the surrounding stagnant blood. The original platelet thrombus was right here. That blood clot is about big enough to occlude the vessel completely. You certainly don't want that desperate situation developing above or below your clamp site while you're peacefully busy anastomosing your vessel. Clearly, therefore, you don't want to produce any thrombi at all in the course of your preparatory dissection. But if you have produced any, it's very much better to know about it. When your vessel dissection is complete, therefore, check for thrombi, like this. Slide your scissor tip along beneath the vessel, almost occluding it, as though you were doing an uplift test. You can see that this vessel is clear. That's not a thrombus. That's the stump of Murphy's branch showing through. This vein has a collection of little thrombi. See them right there? If you see thrombi that size, just leave the vessel alone for 30 minutes, and when you come back, they'll be gone. This vessel has a huge thrombus in it from some major error in technique. It goes from here all the way to here. This vessel will never work. A thrombus that size won't go away. If you see a thrombus that size, abandon the vessel and start over on a fresh one. That's the end of that important digression. I'm sure you get the message. Let's now get back to the action. You've done a careful dissection, you've checked for thrombi, and there aren't any, and you're ready to go ahead. Put on the double clamp. Put it on in such a way that you give yourself plenty of vessel to work on. Murphy's branch, which lies right in the middle, is going to be excised. Slide the piece of background material in right here between the clamp and the wire frame. You'll see why that's important in a minute. Now, divide the vessel, wash out the blood, and then divide it again to remove the origin of Murphy's branch completely. Those vein ends look so distressing when you first see them emptied of blood that it's hard to see how you're going to be able to handle them. The only thing more distressing at this stage is not to have the blue background sitting right up against the vessel. You can see now why you want the blue background right up close like this. Before attempting to handle the vessel ends, flood the field completely with Ringer's solution. Right away, the tissues will float apart and start to look much more encouraging. You're going to keep the wound well flooded all the time while you dilate the vessel ends, remove the adventitia, and get the first 2 stitches in. To dilate the vessel end, pick up the adventitia right here at the very end, lift up on it, and poke around with the dilator till you see the lumen. There it is. Then get inside with the dilator and give a good stretch like this. This 3-cornered stretching maneuver works really well on these short, wide, floppy vessel ends. Here's the way your vein ends should look once you've dilated them fully. Now for the adventitia. Here's adventitia, here's the true vessel edge. unlike the artery, whose adventitia does this, the adventitia on the vein doesn't slide up and down the vessel very much. So the only adventitia you need to remove is the adventitia that you see actually overhanging the true vessel edge. This you can leave alone, but this needs to go. Remember, keep the wound well flooded all the time while you're getting the ends ready. With both ends well prepared, you're ready to suture. Put in the sutures in just the same order as in doing the artery, and take similar sized bites. To anchor the first stay suture, you need to move the background, which till now has been lying on top of the cleat. As with the artery, it's the accurate placement of the second stitch, and particularly the second half of the second stitch, that's the most important moment. With the second stay suture fastened to its cleat, things suddenly start to look quite orderly. From this point on, you don't need the wound flooded anymore. Put in the same number of stitches as in the artery, 2 between each pair of stay sutures, or 3 if it's a especially long gap. The vein is much bigger than the artery, but the pressure is so low that these big gaps between the sutures will seal themselves in no time. You're ready to turn the clamp over now and put in the third stay suture. This suturing looks easy, and it is easy, provided that you've set yourself up for success by good preparation, and provided that with every stitch you do, you see and suture the vessel edge, the whole vessel edge, and nothing but the vessel edge. Let's look at some common mistakes. Here are 2 simple ones: failure to use enough magnification and failure to get into focus. If you can't see it, you can't do it. Look, that was a through stitch. Here's an easy mistake: picking up just adventitia instead of the true vessel edge. On the inside, that gives you a lot of exposed collagen, and the vessel edge just hanging in the lumen. Here's a worse mistake: folding the vessel wall in on itself to produce a doubled edge. The needle goes in and out, and in reality what's happened is that you've gone in and out twice. The true vessel edge is right here. When you tie the knot, that vessel edge is going to end up flapping in the lumen. Here it is. Just one stitch like that will give you this result: a huge thrombus and obviously a failed anastomosis. Last but not least, failure to control your unwanted movement will destroy your chances of success. If your suture line is made of huge holes like this, your anastomosis won't work. If you've avoided all these pitfalls, your anastomosis will end up looking something like this. Let's now get back to the last stages of the action. Cut the stay sutures and flex the leg in order to slack off the tension on the vessel. This will cut down on leakage from the suture line. Remove the blue background, then take off first the proximal clamp, then the distal one. Bleeding should be minimal. If you need to apply pressure, it should be exceedingly gentle to avoid occluding the vein. Leave the vessel strictly alone for 20 minutes before you assess its patency. Here's the best way to assess patency. It's a sort of sliding uplift test done downstream from the anastomosis, that's to say anatomically proximal to it, and in the direction of flow. The forceps must empty the vessel as they move along. If the vessel fills up like that behind the forceps, the anastomosis must be patent. But if it remains empty, like that, then it must be blocked. If your first vein doesn't work, you're in very good company. It's quite uncommon for anyone to get their first vein to work. A vein is a real challenge to your good technique. As you get started, just remember what that technique consists of. Perfect preparation, economy of action, the elimination of unwanted events, and the insistence at every moment on seeing exactly what you're doing. Good luck, and remember, you can't get from here to here.